Good evening. Welcome to iFocus lecture number 28. We are lucky to have Dr. N. Venkatesh Prajna today. He's a star speaker. It's very difficult to get him on live iFocus, but of course online it's slightly easy. So I've been really lucky to get him because he's an authority on fungal keratitis. As you know, we have been having a trilogy on keratitis. Last week it was bacterial keratitis. Today it is fungal and Acanthamoeba. And then next week on Wednesday, next Wednesday, we'll have viral keratitis to complete the picture. So Dr. Venkatesh Prajna is the Director of Education and Training at Aravind Eye Hospital, Madurai. And he looks after the entire Aravind Eye Care system in terms of training. He's also the head of the Department of Cornea. And I just heard that he also looks after the finance, which is a very difficult portfolio to look after in these times. Venkatesh is passionate about teaching, and the way he has streamlined and organized the residency program at Aravind is commendable. He's very passionate about residency training, and also he is very good at and is passionate about fellowship training as well in cornea. And his contribution, you must be aware of, he has edited Ghulam Payment's Principles and Practice of Ophthalmology, a 2-set volume, which we used to read as residents. That was our standard book. And it has been reincarnated in the form of Venkatesh's book. And he's edited it, is the editor-in-chief for that book, which is a fantastic book. I think I would encourage all the residents to read it. It is really complete in terms of its educational value. So I would not waste much time. I would request Venkatesh to take over.
Thank you very much, Santosh. Thank you very much for the very generous introduction. And it's always a pleasure. In fact, Santosh made a joking comment that I don't come to the meetings very often. But when the boss calls, you just can't refuse. So Santosh has been a very good friend of all these years, and so it's indeed a great pleasure for me to join in the show today. I also would like to congratulate the whole team from Center for Sight for conducting this twice a week, and also planning to conduct it for the next few months at least. So what I thought was, in the initial email, Santosh told me to cover both fungal and Acanthamoeba keratitis, and that is what I plan to do in the next 40 minutes or so. Just a minute. Just having one small, but next slide. So is the slide moving, Santosh?
Yes, sir.
Yes, sir.
Okay. So just to start, fungal keratitis, as you can see from the slide, the proportion of fungi to bacteria is much, much higher in India as compared to Africa or in the United States. So if you really see, bacterial keratitis is not a big problem for us. Fungal keratitis is a very big problem for us in that almost 60% and still growing proportion of infectious keratitis is caused by fungi. What is also peculiar is there are different fungi the two most common fungi which cause fungal keratitis are Aspergillus and Fusarium, and they seem to have taken some territory to themselves. In the northern part of India, the studies from All India Institute of Medical Sciences, Aspergillus is noted to be the most common fungi isolated from corneal ulcers. While in the southern part of India, from studies from Aravind, from Joseph Eye Hospital, and from LV Prasad Eye Hospital, clearly tells that Fusarium is more common than Aspergillus. Why is this important? I will be covering up in the later part of my talk. So this infection doesn't get the attention it deserves because it happens in poor agrarian workers. Because as you know, in India, people don't wear safety protection glasses either during agricultural activity or even during welding and other kind of stuff. And because of that, they are prone to corneal abrasions. And especially when they are dealing with agrarian activities, and especially dealing with anything with related to rice or onions, you see the fungi which are present in the agricultural produce often causes an abrasion in the cornea, and that can lead on to a corneal infection. So the most important thing is, unlike cataract, it affects the young individuals. We did a study sometime around 10 years back where we estimated that close to around 7 lakh people in India develop an infectious keratitis every year. So this is not a small number. So why don't we hear about it that much? And that is because it's mostly unilateral, and sometimes it just heals. And even if it doesn't heal, the patient is not really blind because the other eye is still working. So it's more common in agricultural workers. Fungal keratitis are at least 4 to 5 times the morbidity or the visual outcome is poorer as compared to bacterial keratitis. There is no effective antifungal agent. In the field of bacteria, you have antibiotics coming once in 5 years. But natamycin, which was discovered in the 1960s, still remains as the drug of choice in the field of fungal keratitis. And as you know, if the person fails medical treatment, the only option is to do a therapeutic keratoplasty, where the available donor is only 5%. So this is more from a postgraduate exam point of view. You start off by classifying fungi. The ones which are in green are the most important causes of infectious keratitis. The ones which are in white are for passing the exams. So if you really see Candida, especially in the Western world, and the filamentous fungi in all the other places are the most important cause of fungal keratitis. The filamentous fungi again are divided into septate and non-septate. Here in the non-septate, the only thing which we are worried about especially is orbital mucormycosis in immunocompromised people in diabetic, especially uncontrolled diabetics. But for keratitis per se, we are more concerned about the septate filamentous fungi. And even amongst this septate filamentous fungi, the non-pigmented ones, especially the Aspergillus and Fusarium, are the most important cause of filamentous fungi. So even though we don't see Candida, in the Western world, it still occupies a lot of academic interest. And the predisposing factors are typically people who spend a lot of time in the ICUs, especially people with lac ophthalmos and immunocompromised hosts, alcoholics, people who are already deficient with micronutrient deficiency, and protracted epithelial ulceration, you have a higher chance of getting a candida. But the real fungal keratitis which we see here happen due to the filamentous fungi, especially Aspergillus and Fusarium. It actually attacks immunocompetent hosts. In fact, it doesn't bother, it doesn't waste its time in immuno deprived hosts. It just goes and attacks an immunocompetent host. But there has to be a trauma, ideally with vegetative matter, whether it's vegetative matter or not, but there has to be a trauma. And more commonly in agricultural workers, and importantly warehouse workers. When we say warehouse workers, where the grains are stored for a long period of time, those workers are also more prone to develop a fungal keratitis. It's also more common between June and September. So it has a climate preference, and it has a preference for people working in agrarian activities. So whenever you're doing an etiopathogenesis part, it's always nice to correlate it with an example. So here, you can just correlate it something like a terrorist attack. For the first thing for a terrorist to come in is there has to be a breach in the defense, right? The security cordon of policemen or the army people, whoever are standing at our borders, there has to be a breach. So that breach, similar to that breach, is what happens when there is an epithelial defect. So when the epithelium, there is no defect, it is really impossible for the fungi to go and penetrate the cornea. So the first thing to happen is the defense should not be there. And when we say defense should not be there, like the epithelium to epithelium, as you know, is really tightly packed. And when that tightly packed thing is lost, you have something to get in. So when the adherence actually happens, when the fungi gets anchored to the cornea because of the breach in the epithelium, the hyphae starts to grow. And this is something like a house owner. The terrorist has gone inside, rents a place. And as long as you rent a place, you behave very well in the initial period of time. And so the inflammation is pretty less in the initial part. But after some time, the person who's coming on rent wants to own the house. And so for that, they need to slowly release some toxins. It is like the terrorist who has sneaked in has started shooting. And what does he shoot with? He can shoot with multiple toxins. And the fungi actually are much more intelligent than what we think. They can try and release, they just don't release a similar toxin in all the corneas. They can selectively release toxins based on what they combat as a defending agent. So the terrorist has gone inside, has sneaked inside, established himself. And now what happens is the security forces have realized that the terrorist has come and set in place. So what happens is indiscriminate shooting starts. We don't know where the terrorist is. We know that the terrorist is there someplace, and this is where the indiscriminate shooting starts. As you know, whenever there's an indiscriminate shooting, whether it's by security forces or by terrorists, bystanders die. And so similar things happen in these kind of instances where the host or the human corneal or the human immune system is trying to kill the virus but aimlessly shooting, and that causes destruction of the cornea itself. So this is the gameplay which happens. So there has to be a breach of host defense. There has to be an entry of the fungus, get some time to prime itself for its activity. Nobody realizes it. nobody sees it, so it establishes itself. And when it finds that nobody is seeing it, it slowly releases toxins, it releases enzymes, and then the body senses that something is wrong. It starts shooting, and then after some time, it starts shooting indiscriminately and causes destruction of the corneal stroma. In all my years of research, I've come to understand that the body's immune response is equally a culprit, like the fungus, for causing tissue destruction due to irrational exuberance of inflammatory cells. So the traditional teaching is the pain and inflammation are less in the early stages of the disease. Arushi, can I ask you a question? Because Santosh asked me to ask you a question. I'm really sorry to ask you a question. But do you have an answer for why the pain and inflammation are less than bacterial keratitis?
Arushri, are you there?
I'm there.
The simplest answer you can say is I don't know.
It takes time to settle down. Initially,
Okay, so I like to congratulate you. You have learned you learned from my previous slides, but there is some element more to it. See, bacteria, as you know, is a very, very small structure as opposed to the fungi. So when does the whole process of inflammation starts is whether the antigen and the antibody have known each other, have digested each other, and are ready for a fight. So bacteria being small is actually combated by the neutrophils in a much more quicker fashion. And so the inflammatory cascade starts first. But fungi being a much, much bigger structure, it takes a lot of time for the inflammatory cells to go and start trying to eat the fungi. And that is the reason, the size of the fungi is also the reason why the inflammation takes much, much longer to happen as compared to the bacterial keratitis. So from an examination point of view, the first thing you are supposed to answer is, in fungal keratitis, symptoms are lesser as compared to signs. And I just explained to you the reasons for the symptoms to exceed like that. So from the signs, these are the typical signs of fungal keratitis. Commonly, you see non-specific infiltrates. You have pseudodendrites, feathery edges, raised surface. All these things I'm going to show you some example. Can I ask for a volunteer in the hot seat of this? What do you really think is the hallmark of fungal keratitis? Any hot seat participant?
Feathery edges.
So that's a very right answer. In fact, amongst all these things, this is the only sign. This is the only sign which is very typical of a fungal keratitis. So let me talk about the pseudodendrite slightly more. So you can see this this cornea here. The patient is complaining of mild pain, mild irritation, and you can see the conjunctiva is not that very inflamed here, but you can see something here, right? You can see two areas of some vague infiltration, which now shows up slightly better when you stain with fluorescein. Right? It gains it. So when in doubt, when the patient is complaining of irritation, when you don't see much, so I'll just show you the slide before. There is a possibility that we would have missed this, but if you have stained this, you really get this picture very clear for a pseudodendrite, and you stain it with a fluorescein and see it with cobalt blue filter, you see the same lesion much, much more clearer. You can even appreciate that this lesion is not connected to this lesion, and this lesion is not connected to this lesion. So this is what we mean by satellite lesions, and I'll also explain to you more better. So as you can see, this is more like a flower pot dendrite. You know, you see something like a base here, and it's accompanied by stromal infiltration. It's not a clean linear dendrite as you would see in viral keratitis. This is more like a flower pot dendrite. I like to call that way. So it's something like a pseudodendrite. But then staining with fluorescein and seeing with cobalt blue helps you catch these things. So we did a study. This was done around 10 years back. We showed pictures from a trial which I did, the mycotic ulcer treatment trial, the MUD study. And we shared it across the cornea specialists in India and in the US. And you guess what? We are not talking of ophthalmologists, we are not talking of residents, we are not talking of fellows. We are talking of established corneal surgeons. And when they saw the photographs, only 60% of them got it right by just looking at the photograph and guessing whether it was fungal or bacterial keratitis. So none of the clinical features which I had mentioned before was very significant, but one thing which had a lot of specificity to fungus was the feathery edges. And so you were right when you answered, if it is one thing which you need to say whether it's caused by fungus, it is feathery edges. So the next part is the raised surface. See, here you can see, as you can see, this is something like a plaque. You see this part? This is almost like something sitting on the cornea. So this is what we mean by a raised surface. So again, you see, in the initial part of the infection, the lesions are pretty dry because, as I said, the lesions become wet when the inflammatory things progress, and the inflammatory things progress very slowly in a fungal corneal ulcer. And that's the reason why you have a dry surface in a fungal corneal ulcer, and also sort of an elevated surface with a fungal corneal ulcer. So this slide shows the satellite lesions much better. If lesions like this exist, you don't have any doubts. But you have to also understand that these slides are handpicked for me to deliver this lecture and to make it clearer for you. The fungi sometimes don't read textbooks, and so they don't present it in a way where we want them to be. And so without the aid of microbiology in real life, it's really difficult to confirm a diagnosis of fungal keratitis. These are things which are very non-specific, but again, you need to know all these to pass your exams. But of this, the main thing is that flower pot pseudodendrite and the feathery edges are the most important. As you can see here, to be truly to call this as an endothelial plaque, we can call it, but we cannot be as specific as we were with the feathery margins. Immune rings are also a hallmark of any infective keratitis for that matter, and it can be seen, and I'll show you some slides later. When pigmentation happens, the diagnosis is fairly clear. As you can see, very nice pigmentation. This is almost like a leopard skin, right? This was Aspergillus again, and Aspergillus teres. You have multiple things, but when something like this is there, you have to be careful, especially when you are not able to see the pupil fully. This can either be a pigmented lesion, or sometimes you can mistake a sort of a perforated ulcer for a lesion here. And so the best thing to confirm it is to see whether the pupil is round or not. So pigmentation is a hallmark of fungal ulcer. So this was a very interesting case which I published almost 15 years back, 20 years back. I've not seen a more dramatic case than this. I saw an immunocompromised lady who presented with a white corneal ulcer in the right eye and a black corneal ulcer in the left eye, and grew Aspergillus in the right eye and curvularia in the left eye. So you do get different kinds of presentations if you stay long enough in your practice. But this is not very common. Getting a bilateral case, and that too bilateral, one pigmented and one non-pigmented, is not that very common. But these are the next 3 slides which I would like you to closely watch. The first common mistake people might make is between a herpetic dendrite and a fungal pseudodendrite. So first look at the herpetic dendrite. A herpetic dendrite commonly is often a long dendrite. It's not a short one. See, it's a long linear dendrite, and often it actually crosses the visual axis or someplace, but it's always slender. It's not broad. It's not broad. But see this fungal keratitis thing, there is a stromal infiltration always. And if you look carefully, even here, this is it is not very linear like this. See here, this is something which is almost like a mermaid dancing. That is like a viral keratitis. While here, this is much more shorter and also stockier. So that is the main difference. So in real life situation, if you are in doubt, and if the patient is having comparatively a quicker onset and is very clear that the patient is, he gives a history of foreign body fall, I would rather treat it as fungal ulcer for a couple of days before being certain whether it is fungal or viral. So in doubt, treat a dendrite as a fungal keratitis unless it is very, very clear like this. So with bacterial keratitis, you really cannot differentiate. So here you see this is fungal, this is bacterial. We were always taught that the edges of the fungus, you will have serrated margins. Here you see a perfect circle. So you really cannot differentiate between fungal and bacterial after a process of time. You can all these definitions like the pseudodendrite part or the feathery margin part are very typical when you start off in the early part of the presentations, but over a period of time, it just gets merged, and it's very difficult to differentiate between a fungus and a bacterial keratitis. Acanthamoeba keratitis is often taught as a circular disc-shaped stromal infiltration. So here I'm showing you 4 different circular ulcers, each competing for the prize of the best circle. This is a circular ulcer caused by fungus. This is a circular ulcer caused by gram-positive cocci. This is a circular ulcer caused by nocardia. And this is a circular ulcer caused by Acanthamoeba. So if you can see here, this is a nocardial circular ulcer is typically described as a wreath-shaped ulcer here. But see this one. If you just see this, you might just diagnose this as Acanthamoeba, right? This is a perfect circle. In fact, this is a better circle than even this. But so this is why we need microbiology to confirm our diagnosis. But before we go into microbiology, we can use confocal microscopy. And with confocal microscopy, a confocal microscopy cannot identify bacteria because the bacteria size is too low. So fungus can be identified and Acanthamoeba can be identified. So this is how the fungus looks as very, very clear very clear structures in the anterior part of the stroma at even at 56 microns, just beneath the epithelium. You can see fungi. And we did a recent study. In fact, there used to be in older literature, they used to say that you can differentiate Fusarium and Aspergillus by confocal microscopy by the angle of branching. Sadly, this is not true. And you cannot differentiate Fusarium and Aspergillus by confocal. The take-home point for you is bacteria cannot be identified by confocal microscopy. Fungus can be identified, and Acanthamoeba can be also identified. So that is the point. So how about microbiology? The microbiology, more than the findings, the first thing as a clinician you need to know is how do you do the scraping. Especially when you're also doing the scraping, you have to feel what you are scraping. In fact, when you're scraping, you really feel a sense of a grating experience. If it is not smooth, if it's something slightly rough, most probably you're scraping a fungal corneal ulcer. And then the other thing is, most of the time, unless you're going to immediately examine, sometimes in medical colleges, the microbiology department is way far ahead in a different location than the actual ophthalmology department. And before you go there, you will not be able to identify this. So I would really encourage all the residents to do a 10% KOH mount themselves if they really want to isolate and see for the fungus. So here you can either see you can take the scraping through the slit lamp or more easily through the microscope. But see here, especially as I said, this is where what I mean by elevated surface. You can see almost as if you can pass the spatula between the fungus, between the fungal infiltration and the cornea, and you can almost debulk it. This is the same eye. You can almost debulk that entire thing and place it on a slide. And when you do it like this, when you take samples like this, it's very unlikely that you will not see the organism. And you can also plate it in blood agar and potato dextrose agar for culture. So again, in the microbiology, you have to talk about staining methods and the culture methods. In staining methods, you have to classify into light microscopy and fluorescent microscopy, because in light microscopy, you can see fungus through 10% potassium hydroxide, through gram stain, through GIMSA, and through GMS. And with fluorescent microscopy, if you have access to fluorescent microscopy, you can have calcofluor white staining. So whenever somebody asks you a question, try to classify. If they ask you, how do you confirm the presence of fungal corneal ulcer, you can just say invasive, non-invasive, and in non-invasive, you can start off with confocal microscopy. And in invasive, even though it's not invasive, but you still are scraping the epithelium and doing it, you can do it, you can classify it as staining methods and culture methods. And in staining methods, classify into light microscopy and fluorescent microscopy. If you're not prepared with an answer, you're just going to say KOH, and you're not going to tell anything further than that. So the whole thing of preparing for an exam is to classify things on your in your mind and keep everything in that kind of a format. So as soon as you're asked that question, you start classifying it. So this is how fungus looks like. A lot of something like a sugar cane. You just see things like this, very, very, very easy to identify in 10% KOH. But you can also see sometimes this is the size of the fungus. You can see how broad it is. But this is an ulcer which has also nocardia. So nothing prevents another organism from invading the same cornea. So in this cornea, you have nocardia and fungus infecting the cornea, but you can see this size difference, wherein the fungus is more like much thicker, and you can see the nice septate, while nocardia is much, much thinner. KOH can also pick up yeasts, so especially for Candida. But if you just have only a small specimen, you don't have enough specimen, and you're not sure whether it's bacteria or fungi, the wisest way would be to do a gram stain, because in a gram stain, you can identify both bacteria as well as fungi. So it's especially useful for identifying coexisting bacterial infection. As you can see, this is another case where we can see in gram stain, very clearly fungi and nocardia with the bluish hematoxylin nodules. And this was a very interesting case in which a simple fungi, and this was a very small ulcer, and we scraped it. And when we scraped it, we could see gram-positive cocci, we could see fungus, and we could also see gram-positive bacilli, just by one scrape and subjecting it to a gram stain. So these are unlikely events. Usually, 90% of the time, you identify only one organism, only 8 to 10%, you identify multiple organisms. So yeasts also show up. Again, this is for completion's sake. We don't see much yeasts here. Yeast can also be picked up by gram stain. And GMS, these are some fancy stains. The basic thing you need to have is a KOH in grams. And if you have specimen only for one, just 2 grams. So fungi for completion can be identified with GMS, as well as if you have an access to fluorescent microscope. This is the easiest way it will show up. Fungi shows up very easily. The only disadvantage is that this is expensive. But once you see it here, it's much more reliable. But for all practical purposes, if you don't have a lab, if you don't have an access to lab, just do 10% KOH. If you have access to lab, and then if you don't really know whether it's bacteria and fungi, and when the specimen is low, then you do gram stain. All these are for examinations and for some research purposes. In culture, the common agar plate which we use at Aravind is potato dextrose agar, but you can also use a Sabrot's dextrose agar without cycloheximide, and you can see fungi growing up like this. So after from the culture plate, you can do a lactophenol cotton blue mount, and then you can see the conidia, and that is why then it becomes very clear. So at this point of time also, you know that something is growing, but only when you do an LCB mount, you're very clear that it is Aspergillus flavus. It's very interesting how this was actually termed as Aspergillus, because at that point of time, most of the scientists were also clergymen, were people who were involved in church activities. So aspergillum is something like where you sprinkle holy water on people after a mass. So when they identified, when they saw this in the microscope, they saw it looked like an aspergillum, and that is why they call it as Aspergillus. Very interesting. And also a point to understand, at that point of time, people were doing multiple activities just to sprout their interest. And so this is how Fusarium looks at it. And always look at both sides of the plate, because the pigmentation you see can be on the other side of the plate. And Fusarium solanae, a mount, looks like a boat, looks like a canoe. In fact, here, as you can see, the conidia looks more like a boat, while the Aspergillus conidia, I just showed you how it looks. So these were, again, some of the fungi which we grew up in our lab. These were, can you imagine that these are from cornea? This looks like multiple pizzas and dosas and other things, but these were all grown from corneal ulcer patients coming from the hospital, giving us some interesting times to sort of diagnose this with pictures, because these are things which we don't see quite often. So PCRs are more, when you have very small sample, the best way to identify a fungus is through a PCR. The advantage is it requires a very, very smaller test sample, but since it's very sensitive, you have to be very, very careful in actually interpreting the results, because you can have artifactual amplification of non-pathogenic organisms. So how do you manage a case of fungal ulcers? So it will be medical and surgical. From the surgical TPK part of it, I will be covering it along with Acanthamoeba. But in the medical part, we can use eye drops. We can inject the antifungals into the stroma, and we can give oral antifungals. Amongst the eye drops, the drug category, the main categories are mainly polyenes. So polyenes can either be larger polyenes as exampled by amphotericin B, or smaller polyenes as example by natamycin. And both of this actually work in some sort of disrupting the ergosterol, which is the cell membrane of the fungi. The other drugs, the imidazoles, triazoles, and the other drugs actually work by causing inhibition of production of the cell membrane. While the main drugs, the amphotericin B and natamycin work on destroying the cell membrane, causing disruption. These other drugs cause problems in actually formation or reformation of the cell membrane. But this is one thing which you have to be clinically very, very careful. This is a patient who was being treated with natamycin. If you are not careful, you will think that the ulcer is still not healed. This is actually not an ulcer. This is just the precipitation of natamycin deposits because it is like a suspension. And one thing you have to instruct the patient is when you're giving natamycin to the patient, please ask the patient to at least shake it 10 to 15 times before he applies the drop once into the eye. So this is one study which I spent a lot of time doing in my life, and I published this in 2013. This drug very clearly showed that natamycin today, even if you have voriconazole, natamycin is a much, much better drug, especially for fusarium. And that is why the MUD study concluded that natamycin was better than voriconazole. And especially if it's for fusarium, natamycin works much better. So this is how the ulcer heals. We have to know how the ulcer heals. The first thing is to see the edge. See here, this is an active ulcer. You can see that the edges are much more frayed here. As the patient starts to apply the eye drops, the edges become more blunted. Here, the edges become more rounded. The same patient over a period of time, the scar becomes more rounded, and after some time it fades. So this is how you have to look. The first thing is to look at the edge. Don't look at this part. Don't look at this part, you will get fooled. Just look at the edge, and that tells you all the story. And if it doesn't heal, you always look for diabetes, a chronic dacryocystitis, which is very common in our country, and also look for contamination of medications. Natamycin works against fungi, but paradoxically, Pseudomonas loves natamycin. So if your patient is going to have the drug very carelessly, there is a chance that the Pseudomonas contaminates the natamycin, and the patient will seed his fungal ulcer with Pseudomonas and develop into a multi-organism causing ulcer. So this is very important, especially in our settings. Always inspect what the patient is using. So I said we just covered topical antifungals. Intrastromal, these are the two drugs which are known to be injected into the stroma. You have to be very careful. You should not be penetrating the cornea. Both voriconazole and amphotericin B. Here is one of our patient alone. You can see this is immediately after the injection. You can see some blood here over a period of time. Of course, the patient was also put on topical antifungal, and over a period of time, it just healed. This is just one of the time where it healed. But when they actually did a randomized control trial, they showed no added benefit of adjuvant intrastromal antifungals. In fact, they say instead of giving intrastromal, you can give intracameral amphotericin B. But again, no randomized control trial has been done to prove this. Unless we do a randomized control trial, there's no way that something can be really established. So what about oral antifungals? The oral antifungals, again, right now with voriconazole and ketoconazole. Ketoconazole is the most common thing to start off. But before you start the patient on ketoconazole, you have to do a liver function test. And unfortunately, we did a big study and we published it called the MUD2, we in fact said there was no benefit in adding oral voriconazole. Be careful about oral voriconazole. Oral voriconazole causes hallucinations. So sometimes it can lead to very bizarre activity from patients. So oral voriconazole is not a it's not a casual drug to try on people with fungal ulcers. So Dr. Namrata Sharma actually popularized this protocol, the topical systemic targeted therapy. The first line treatment, no controversy, topical natamycin 5%. You can either add oral ketoconazole in severe ulcers. When I say severe, you don't have a choice, you can try, but RCTs have not shown anything. Second line of treatment, you can add topical voriconazole. And the third line of treatment is intrastromal and intracameral. And the fourth line of treatment is therapeutic keratoplasty. So this is the TST protocol as popularized by Dr. Namrata Sharma. So collagen crosslinking again was touted as one of the treatment. Two possible mechanisms. One is the crosslinker itself. The riboflavin itself can kill the fungus. That was one of the postulations. The more popular explanation was because it strengthened the corneal stromal collagen, it actually prevents the stromal melt, and so increasing the resistance of corneal tissue. So these are the two mechanisms by which cross-linking works, either for bacterial or for fungal ulcer, but cross-linking works very well for bacterial ulcer, does not work well for fungal ulcers. So in fact, for fungal ulcer, the only way things work seems to be at this point of time, topical therapy, and if not topical therapy, if it's worsening, better to go in for surgery. I'll just quickly pass on with Acanthamoeba keratitis, and then come for TPK. When I come to TPK, I'll just cover for both. So Acanthamoeba keratitis, as you know, it's a less of a problem, but more of an exam question. So you need to know that it exists in two forms, the trophozoite form and the cyst form. The cyst form gives it the dormancy and also allows it to remain for a long period of time. So here, again, this also can cause a pseudodendrite, but here the classical feature is the radial perineuritis. We might think that ring infiltrate is a classical picture, but any ulcer, I showed you 4 ring infiltrates caused by 4 different organisms, but the radial perineuritis, as you can see here, as though just along the nerves, you can see very nice pictures here. And that is also the reason why the people with Acanthamoeba keratitis have got very severe pain. The second thing with Acanthamoeba keratitis is its propensity to involve the limbus very quickly. Limbus and secondary glaucoma is very, very common. As you can see, the angry looking vessels near the limbus, and as you can see, almost like a PUK type of activity here in the limbus. So Acanthamoeba has a propensity to cause limbus and also a melt. As you can see, it's almost eaten up the entire peripheral cornea, and here, as you can see, even the sclera is sort of thinned out. You can see the choroid seeping through. Very, very typical of long-standing Acanthamoeba keratitis. This can also be visualized in the early stages by confocal microscopy as bright spots, as double wall cysts, and also as signet rings. So these two things are very common. So I want to repeat a point that IVCM today, the laser IVCM today cannot identify a bacteria. It can identify inflammatory cells. It can identify fungus. It can identify nocardia. It can identify Acanthamoeba, but not a bacteria. So that is one thing which we need to understand. So here also, the typical thing in Acanthamoeba is you can still see it in KOH and grams. But the question they always ask is this culture on non-nutrient agar with E. coli overlay. So why do you want non-nutrient? Why do you want E. coli overlay? Because we want the Acanthamoeba to start eating E. coli, and so we can see the track marks. That is why we want to overlay it with E. coli. So why do we want to have non-nutrient agar? We don't want E. coli to eat everything and become a E. coli colony. So we want E. coli just for Acanthamoeba to feed in. We don't want E. coli to completely overlay. And so that is why you need a non-nutrient agar with E. coli overlay. Again, as I said, you can see double wall cysts typically seen in KOH and grams. And this is how it looks like in NMA with cysts. The principles of therapy is it runs into months. When we say Acanthamoeba treatment, we usually say we treat the patient for 6 months, 6 to 9 months of treatment. The common medical treatment is with biguanides, diamidines, and aminoglycosides. The common biguanides, see, if you really see all this, these are not specific drugs for Acanthamoeba. These are all antiseptics. The way they work is these are just antiseptics. They're highly charged molecules. They bind to the phospholipid membrane of the Acanthamoeba, causing lysis. So you have to understand that there's no specific drug of choice for Acanthamoeba, and this is just plain plain antiseptics. The other drugs which we can use for Acanthamoeba are aminoglycosides, which are readily available, and you can use it as combination. And the only thing you can start up with a PHMB and add with neomycin. And so while PHMB can take care of trophozoite and cysts, neomycin can take care of the trophozoite. So oral miltefosine, this is being touted, but people have already have a lot of doubts about this treatment. But in the Western world, it's being touted as one of the most promising treatment for Acanthamoeba. Personally, I don't feel that it works very well, but we just need to know this at least from an exam point of view. Now, this part is important. I just have like 5 or 6 more slides to finish my talk. So I'm covering therapeutic keratoplasty as a common part for both fungi and Acanthamoeba keratitis. The first common question they ask is, what are the indications for doing a therapeutic keratoplasty? And the first thing you need to say is perforations. And if they ask what perforations, at least you should be able to say perforations more than 2 or 3 millimeters, because smaller perforations you can medically manage with glue or with pattern bandage. The second thing is impending perforations. That is my second point. The third point is progressive non-healing ulcers in spite of adequate and appropriate therapy. Every word is important here. So the patient, if he doesn't use adequate medications, the ulcer is not going to heal, and that is not an indication for going in for surgery. So the patient should have been compliant with treatment and should be using the appropriate treatment. It should have been guided by microbiological investigations. So only if they use an adequate therapy and an appropriate therapy, not healing, then go ahead for doing a keratoplasty. When the ulcer is threatening to involve the limbus, you saw how the Acanthamoeba ulcers go and involve the limbus. So threatening to involve the limbus, you need to actually use this. And also severe secondary glaucoma, secondary to corneal infection. So this is a very, very important question for your exam and for your clinical practice also, especially progressive non-healing ulcers in spite of adequate and appropriate therapy. So what is the goal of TPK? See, a goal of TPK and a goal of optical keratoplasty is different. An optical keratoplasty is for vision. There you can do a very good round graft to keep everything in harmony. Here actually you just want to get rid of the infection. So you really can't do a very, very round graft. The main thing is to take care of all the infected tissue as much as possible and to also maintain the structural integrity of the globe. So we are actually waiting for a better day. We just want to take care of the infection, something like an amputation. It's really not an amputation, but in fact it's an amputation of the cornea, and also to actually take care of the infection, so that when we go back, we actually look, we once the ulcer heals or once there's no reinfection, then we can go and do an optical keratoplasty. So this is all the steps in TPK, but I'll just show you with a picture. The first thing is to measure. Just measure so that you cover the completely infected tissue. Even though the infection looks as if it is confined to this area, always try to have at least a 1.5 millimeter, if it allows, a diameter in both these sides after you measure. Then you trephine it. Make sure you leave a partial trephine. By that time, you can do a complete trephine of the globe. The idea is the donor tissue. The idea is if you destroy the donor tissue, if that's the only tissue, you stop the surgery at this stage. But if you have prepared a good tissue, then you take out the infected corneal tissue out. More importantly, spend some time to flush out the anterior chamber, all the pus out of the anterior chamber. If a membrane is covering the lens, with the forceps, peel off that membrane, put a donor tissue, and then suture in place. And always do a big peripheral iridectomy. Second, therapeutic keratoplasty are notorious actually for going in for secondary glaucoma, and you should do a sort of a PI for these kind of patients. So there can be 3 sequelae of TPK, to be simply put. The first sequelae is a TPK resulting in a clear graft. This is not very common, but if you're going to see here, I have decided at this point of time that the ulcer is progressing. But as you can see, you have very clear margin, reasonably clear margin. Did a graft, and over a period of time, it started to clear, and it's almost very, very clear graft. So this is sort of rare when you have an ulcer like this and you take a decision to do surgery. But these kind of sequelae are more common. See here, this is an active fungal keratitis. This is initial with medications. You see that the ulceration has not resolved. In fact, the suppuration seems to be more. And so immediately we do a therapeutic keratoplasty. As I said, one of the aim of therapeutic keratoplasty is to get rid of infection. We've got rid of infection, but since this is an inflamed eye, slowly, as you can see, edema starts developing, a rejection starts developing, ultimately leading to a failure. But this is still, it may be a failure from a graft point of view, but as far as I'm concerned, it's a very successful event, because we've not got a secondary infection, because this becomes a quiet eye, and when we do a graft in this size 6 months hence, we would possibly get a result like this, possibly. But so our aim might not be, see, don't aim for this, because if you aim for this all the time, you might miss out. You will always be worried about doing a round graft. Don't try to do it. The first principle is take out the infection. We'll do an optical graft later. So this is another sequelae, as I said, TPK rejection failure. There is another sequelae of TPK where instead of rejection going in directly for rejection, it can go in for reinfection, then cause a failure. See here, it's a fungal ulcer, a large ulcer, much larger ulcer. Immediately follow up after TPK looks reasonably okay, but when the patient comes for 30 days post-op, you see the sutures broken and the infection returning, and then we did a repeat TPK, and which ended up in failure. So a TPK sequelae, the graft can be clear but uncommon. The graft can go directly for rejection and to failure. That's quite common. And then the other common thing is the graft can go for reinfection and then go for a failure. So as long as you end up with a quiet failure and you have salvaged the globe, be happy, because we can always go in for an optical graft later. In Acanthamoeba keratitis, the common teaching is don't go with hot grafts. As I told you, the treatment for Acanthamoeba keratitis runs into months, 6 to 9 months. But usually if you persist, and if there's no secondary glaucoma, and if the sclera is not involved, we can wait with medical treatment. It usually heals. And then when we do keratoplasty. In Keratitis, the graft survival is excellent. So this is the last point, last slide in my presentation today. And we are finishing on time. The first thing is the distinct clinical features, like as you said, feathery edges, satellite lesions, all what you say are seen only in the early stages of ulceration. So that cannot just be your point to say that it is this. That just gives you one thing that probably we are dealing with a case of fungal ulcer. Every ulcer has to be confirmed by microbiology. It can be simple microbiology, just like a KOH smear, or a complicated one like a calcofluor white. It depends on the infrastructure system you have, but you don't require a microbiologist. Any ophthalmologist would have can do a KOH mount if it's just trained for by just doing 2 or 3 cases. And appropriate treatment strategies. For doing an appropriate treatment strategies, you need a confirmed microbiology with a distinct clinical feature. So if you know, I showed you some of the slides which had multiple organisms in it. As long as you're not going to, if you're not going to counter all those microorganisms, you're not going to make the ulcer heal. So you need to really have appropriate treatment strategies. And then the patient also has to be compliant with medications. That determines the successful outcomes. In fact, we have had bad results in which we were pretty aggressive in going ahead with TPK. And what really happened was when the patient was not compliant with medications, especially post-TPK, the infection returned. But having said that, if the ulcer is progressing, at the first sign of non-responsiveness, I go back to this slide. At the first sign of non-responsiveness, like here, and where you have healthy, comparatively healthy margins, healthy, clear corneal margins, you have a much, much better chance of getting a clear graft rather than in these patients when you start off pretty late. And then in Acanthamoeba, also, as I said, you have to be patient and the patient has to be patient. And both of you, the patient also doesn't have too much of a choice because there's not many people out there who like to treat corneal ulcers. So you just need to be patient. And more importantly, don't just treat the ulcer. Don't forget that the patient has pain. So treat the pain. That's very, very important. I've seen people measuring epithelial defects, saying that this has reduced, but then the patient will be having severe pain. So always treat the patient's symptoms also alongside your treatment, and you will do very well. So in an exam question for fungal keratitis, the common question is, why are the symptoms less in the early stages of fungal ulcer? The second question, which is very commonly asked, is the signs of fungal corneal ulcer. Microbiology, what do you do? So as I said, stains, simple stain, and then special stains, and then culture, and then LCB, and then treatment. Treatment will be topical treatment, intrastromal, then systemic treatment, then corneal collagen crosslinking, and then go for a TPK. So this is how you do like a stepwise thing for an exam. And then the final thing they often like to ask is, what is the post TPK management of a fungal ulcer? The answer they expect is, don't use steroids for a period of at least 2 months, because steroids are known to reduce the local immunity and causing reinfection of the fungus. So thank you very much once again for this opportunity. I would like to thank Santosh and his team for organizing this meeting. Thank you very much.
Thank you, Venkatesh. Wonderful, very nice lecture, very comprehensive. I think we have a bunch of questions for you. Harika has collected all the questions and she'll answer.
Yes, sir. I'll be taking the questions one by one, sir. The
Yeah.
first one is, how do we look for mobile and non-mobile ulcers?
Pardon?
How do we look for mobile and non-mobile ulcers?
Mobile and non-mobile ulcer. I really don't understand the question. Do you understand the question, Harika?
No, sir.
Okay, then I think we'll pass.
Okay. So the next one is, when it is not possible to differentiate the organisms, can we go for a combined therapy?
So that is a, so don't make it as a routine. I would advise you, see, this 10% KOH business is not as difficult as what it does it. I don't advocate combined therapy. I would advocate combined therapy if after your investigations you're still not able to find out which organism you're dealing with. At that point of time, you can consider. But then in a situation where combined infection happens only in less than 8%, we are not justified in giving your as a combined treatment.
Okay. So if we have to say, what is a typical clinical feature of an Aspergillus and a Fusarium, and which one is more aggressive among the both?
So definitely there is no doubt that Aspergillus is a much more virulent organism. There is no doubt. But clinically, you cannot differentiate. And I also made a statement that we published last year in ophthalmology, that even by confocal microscopy, you cannot differentiate a Fusarium and Aspergillus at this point of time. Aspergillus is a much more aggressive ulcer than Fusarium.
So the next question is, can we use fortified drops in fungal keratitis?
Not really, but you can use a combination of drugs like natamycin and voriconazole. You can use, but let me just tell you my passion, which this thing in just one sentence. Right now, the whole principle of our management is killing the fungus. But actually, that is not the end of the disease. The disease is a culmination of the fungus and the host response. So as I see it, in years from now, it would be an antifungal combined with the topical acting local immunosuppressant. The UVA guys, they use the MABs, the interleukin IL-17 antagonist. If we are able to shut down selective interleukin responses, that is the way to go. That is the way to future, and it is not. We are not really imagining things. We are trying to go towards that line of management over a period of time. Even in COVID, that's what we are now getting to hear, right? All the cytokine storm and other kind of a business. So we need to get into that kind of a mindset. That disease, it is like killing a terrorist and then imagining that the whole problem of terrorism is gone. You have to really understand what caused it first and also act on that.
Yes, sir. So the next question is, what is Pythium keratitis, and does it mimic fungal keratitis?
So I didn't really include that because Pythium is not typically a fungus, but it is very relevant for this talk. A very nice question. It mimics fungal keratitis clinically, but it's much more aggressive. But the real clinical feature is the tentacle-like growth in the cornea. It is also reticular, and it's also sometimes causes a PUK type of a thing. And Pythium does not contain ergosterol. That's why it's basically not a fungus, but it mimics a fungal keratitis, and it does not respond to antifungal drugs, responds to linezolid, at least if it does to one drug, it's probably linezolid, but the best and the easiest way is to go in for a TPK. But Pythium is not a fungus because it does not contain the typical ergosterol.
Okay. So the next question is on corneal scraping, sir. Where and how to take the corneal scraping, and what are the precautions we need to take when we are doing the corneal scraping?
So I'll tell you this. If my first year, if my fellow comes who is very new into the department, when they do a scraping, the results are negative. And when the fellows become more mature, the results are positive. It's not they have become very intelligent. It's just because they become more aggressive. The thing is, apply drops and aggressively do scraping. The so-called margin base of the ulcer is for exams. Just scrape this way and that way, get some tissue out and give it to the microbiologist. Don't give air to the microbiologist. They cannot diagnose. So the only thing is do an aggressive scraping and don't worry about perforating. You know, I always tell this, if it perforates, fine, nothing is going to happen. A 1 millimeter or a 0.5 millimeter perforation, it's like a therapeutic healing. It will just, in fact, that will really get down the hypopyon and we'll have a much better ulcer to quick. So my only advice is please do vigorous scraping. Don't worry about perforation, but do a scraping. And I also made a point during my presentation, when you are scraping, feel that grating sound. That's very important. If it's grating sound, it is definitely not bacteria. A bacteria is like, it will look as if you are passing the spatula on a butter. Well, this will be like something like a carrot grate thing. Once some fellows start realizing it, they will understand what I mean. Yeah.
Okay. So the next question is, what are the precautions we take or modifications we do in the pre-op, operative, and the post-op period in a TPK in a case of fungal keratitis?
So the first thing, as I said, is measure. And also, the other thing is, as I said, when you measure, you sometimes feel that it is almost to the limbus, but not to the limbus. But I always say, give it 2 more millimeters. The second most important step during the procedure is to do a peritomy. Because if you don't do a peritomy, you will actually refrain from going to the periphery. If you are going to the peritomy, if you have really done a peritomy, you're really not scared. You can take out some of the sclera also along with cornea, and also go for an eccentric graft. Sometimes in some areas you can include sclera, but the sclera need not be taken 360 degree also. So that is one part. And then the second most important part is after peritomy, a very controlled entry into the chamber, because it is an angry eye with full of pus. And if you're going to debulk it, you're going to land into trouble. So after you make your marking, you do like a partial trephining. You can do a paracentesis. You can sometimes debulk the chamber and then do a controlled entry. You don't need to enter with your trefine. You can just enter with a nick in the blade and then do it. And then please do a PI. So the two major problems, if we don't end up with a reinfection, if we don't end up with a secondary glaucoma, then it's a very successful surgery. Don't aim for a clear graft. If you get a clear graft, be happy. If you aim for a clear graft, there is a high risk that you will end up leaving a part of the cornea thinking that I want to have perfect suture, and that is where the infection will restart.
Yes, sir. The next question is, what parameters should be monitored while giving amphotericin infusion, and what's your comment on the cumulative dose?
I'm not a big fan of amphotericin. In all my experience, I've done more drugs. I really feel amphotericin is something like a toxic drug systemically. I don't recommend it. No personal pluses or minuses, but I've come to realize that 1 or 2 case reports is not going to be a big thing. So if you're going to give systemically, you can give oral ketoconazole or oral voriconazole. But even this antifungal drugs, they are very tricky drugs. I'll just tell you one example. I'm deviating from your topic, but just to give why I mean by tricky drugs. We were doing this MUD2 study, and we were doing a placebo-controlled oral voriconazole study. I had my doctor call from Coimbatore telling me that one of the patient is telling me he's on this drug oral voriconazole for almost 6 weeks, and he's saying that his wife is calling him. And the problem is the wife has died 10 years back. I would have called it as a joke. Then I get another information, another another unrelated patient from Pondicherry in another center having similar complaints that the father is calling. The father was dead 10 years back. So these are not two isolated incidents. It is acting someplace in the brain. It is acting someplace in the brain. You know, sometimes we can just call it as isolated incident, but it is too much of a coincidence. Be careful with this antifungal systemic medications is what is my advice. Yeah.
Yes, sir. And what's your opinion about cauterization of corneal ulcer and also on cryotherapy of these corneal ulcers?
You can do whatever you want to kill the organism. Just kill it. If you don't have tissue, if you don't have corneal tissue, you just do anything to do it. You can just kill it.
Okay. So
But
what?
I add the statement saying if you don't have tissue.
So the next question is, what would be the minimal time for graft failure?
In fungal keratitis. So it depends. Sometimes, see, basically, we start off with a bad tissue, right? We say therapeutic grade tissue. That means it's a lousy tissue. We start off with a bad tissue which is bound to fail. So in that condition, it's never going to recover right from day one. So you are not starting up with if you are, this question is very relevant. If you're going to say I start off with the same quality tissue to do with keratoplasty for keratoconus and then for fungal ulcer, and then you compare. So you really don't bother too much about failure or rejection. You just be careful only about reinfection and secondary glaucoma. If the patient is rejecting and graft is failing, I'm very happy. As long as there's no secondary glaucoma, as long as there's no secondary infection.
Okay, sir. So the initial question, there is a correction. The student was asking for how to differentiate between mobile and non-mobile hypopion.
Oh, okay. Doesn't matter. Doesn't matter. The problem is the priority in teaching. You know, we are supposed to say cheesy hypopion, non-mobile hypopion, infective, that the fungal hypopion contains fungus, while the bacterial hypopion is inflammatory. Anyway, I'll keep quiet. It's not sometimes it really doesn't matter.
Okay.
But if you just give me time, I'll just tell you one thing which is really going to change, which has really happened in pulmonary fungal infection. See, what they have done is they are using some chemical probes, and they put a bronchoscope, and there they just spray this chemical agents, which will go and actually tag on to the bacteria or to the fungus, and then fluoresce. You can just use a screen, and then you can fluoresce. And what happens is, wherever the fungus is there in the lung, this probe, this chemical probe, will go and attach. So you will know, where, like a CT scan, that 10% of the fungus is getting, 10% of the lungs is getting infected there. And the second important part is you can use the drug. You can use a selective drug, which will, in micro doses, you once again inject. It will just go and attack exactly the tagged on areas. Something like a drip irrigation, not like a flow irrigation. So this is not fiction. We've done a very, very similar study, which we published in AJO 3 months back. Using the same technology, we could identify the organisms using this chemical probes from the cornea. So we will be following it up and see whether micro dosing of drugs to selected areas in the cornea will work in the future. So I kept this talk very, very basic, but I really want to sell this concept that the way we are treating an ulcer today is wrong, because we are just killing the agent. We are not counteracting the disease. The disease is an interplay between the agent and the human being. as long as we are not addressing that interplay part, as they have really done in rheumatological disorders or in oncology, as long as we are not going to address that part, we are not in the correct realm of thinking. But at least now people are starting to realize it. People are starting to see it. And so I really want us to focus on that part. If one message has to go from here, just like the cytokine storm of COVID, there is some kind of an immunological storm which is happening in this, which is not being treated by us at this point of time. Maybe one of these guys who are attending this meeting will eventually discover that.
Thank you, sir. One more question is, what is the treatment of hyperacute rejection in TPK following fungal ulcer? And is there any role of oral immunosuppressants instead of topical steroids?
So I don't use topical steroids. In fact, I was mentioning that we don't use topical steroids for the first 2 months. Rejection is a very good result. This is the 5th time I'm telling this thing. Don't worry about rejection. Don't treat the rejection and get a reinfection. That is the bottom line. I really want you to take it from it. If you get a clear graft, I showed you one. Be very happy, be very thankful that you got it. Otherwise, if you don't have secondary glaucoma, if you don't have reinfection, you have won the game. So I'm not going to treat a hyper emergency rejection. I'm just going to allow it to fail with gracefulness, and then wait for a good day, wait for a quiet day to go ahead and do a clear graft.
Sir, how should the follow-up of these patients be after therapeutic keratoplasty?
So therapeutic keratoplasty with fungus is very tricky. We keep the patient for 4 post-op days. We don't give topical steroids at all. We continue topical antifungals. We also really monitor the pupillary movement. We would like to keep the pupils semi-dilated at least. We would like to see the patient every 2 weeks. The 3rd to 4th week is the trickiest period. Always as soon as you see the graft, we'd like to see the central part of the graft to see whether it's clear or opaque. Always see the suture ends. That is from where your fungus is going to regrow. So that should be your area of interest rather than the central part of the graft. So watch for that to happen, and the first instance, aggressively treat, and if not, even give intrastromal at that point of time if you see an infection, or if it's really moving quickly, go for a quick regraft. Salvage the globe, no reinfection, no secondary glaucoma.
Okay, so the next question is on regraft, sir. When can we do a regraft in post TKP in fungal keratitis?
See, as long as it is quiet eye, anytime after 3 or 4 months, you should be the eye should be quiet. So there's no sacrosanct period like herpes where you wait for a year to do a graft. Here, the primary focus is already taken care of, right? There's no immunological memory as such, except for the graft which we are going to put. Anytime after 3 or 4 months, we can go ahead and do a graft.
Okay, sir. So does the management differ in demataceous and non-demataceous fungi?
So yes, once again, a very nice question. With demataceous fungi, I like to do aggressive scraping every time the patient comes for follow-up. So it's very easy to scrape it and debulk the tissue as much because it grows like a cap. So Curvularia or any other organism, if you scrape every time the patient comes, you just scrape. You debulk, while I will not do that much of an aggressive scraping when I'm doing with a non-demataceous fungi. Otherwise, the treatment is the same.
Thank you so much, sir. We are done with the questions. As sir was saying, we are actually very lucky to hear this topic from you. Each and every sign was illustrated very beautifully. Thank you so much, sir.
Thank you.
Thank you, Venkatesh. Real true Talaiva lecture. Very nice, wonderful. And thank you for very patiently answering all the questions. Thank you.
My pleasure, Santosh. And all the very best. And thank you for doing this for the postgraduates.
Thank you. Hope to have you back again with some other.
Sure. Thank you. Bye-bye.
Yeah. Next Wednesday, that will be on 9th. We have a talk on viral keratitis by Dr. Varun Malhotra. So please be there. Thank you so much. Good night.
Good night. Bye-bye.
Thank you, sir. Good night.